Hello, welcome to HFMAtalk. I'm Sarah Day, Policy and Research Manager at the HFMA. I'm joined today by 3 Directors of Finance from across the acute, community and mental health sectors to discuss cost improvement programmes and efficiency savings. So thank you all for being here. And let's start off with some introductions and a bit of context about your organisations. So Sarah, would you like to go first?
Hi, I'm Sarah Connery. I'm the Director of Finance and Information at Lincolnshire Partnership Foundation Trust. We provide a wide range of mental health, learning disability and autism services across Lincolnshire with a population of about 750,000 and we provide services for all ages.
Thanks Sarah. And Chris?
Hi, I'm Chris Sands. I'm Deputy Chief Executive and Director of Finance and Strategy for Derbyshire Community Health Services Foundation Trust. We provide services across the whole of Derbyshire, from children's to old age adults, a range of services from community hospitals to mental health to learning disabilities, children's services and public health services.
Thank you. And Ian?
Hi everyone, my name's Ian Moston. I'm the Group CFO for the Northern Care Alliance, which is a group that comprises Salford Royal Foundation Trust and the Bury, Rochdale and Oldham elements of Pennine Acute. Depending on geography, we provide a range of specialist DGH, community and in some instances social care services to the populations that we serve.
Thanks Ian. So I said at the start that we're going to be talking about cost improvement programmes, but is that actually the right term, and does the language we use matter in this context? And Ian, I think you have some thoughts on this.
So we, for a long time, Sarah, not used the language of cost improvement. We turned around 6 or 7 years ago to use the language of better care at lower cost, which was designed to show the organisation and engage the organisation in a way that meant we weren't just focused on the cost side of this, but it had to run in tandem with our quality improvement strategy, which was an important part of the organisation.
And is that similar for you, Chris?
Yes, we've taken a similar approach. So a number of years ago, our medical director came up with the term Sustainable Quality Improvement Programme. So we talk about scripts within our organisation. And similarly to Ian, we also look at the quadruple aim as well, about improving healthcare, about improving patient experience, about improving the experience of working within the NHS, but also about reducing per capita cost of care. And so we try and make our decisions using that sort of framework, which means that we're not just focusing about the cost, we're focusing around the patient experience and improving outcomes as well.
We've tried similar with variable success, I would say, in Lincolnshire Partnership and indeed across the Lincolnshire system. And I think some of the challenges are around how in the NHS we have quite short-termist financial planning. So I think in terms of the capacity of clinicians and indeed the finance team in terms of how they're supported to look beyond the 12-month sort of cash in the bucket approach can be quite a challenge when we're held to account for, you know, how we're going to land on the 31st of March each year. So it's really important to hold the line on looking at value and quality outcomes with finance as the byproduct. But I think it's a challenge sometimes to keep the organisation and indeed our regulators on that page.
Ian?
I'd agree with Sarah that you do reach a kind of capacity point or a tipping point with the engagement piece, and that everything has its lifespan. You know, my reflections on better care at lower cost, in part, I think we'd have been better if we'd have used the word and rather than at. In the first instance, it's the sense in the organisation after a few years was that it accented the lower cost element greater than the better care piece, and so we got a kind of diminishing response over a period of time. We're at a point now where we're looking at whether we can shift it. we're using the language at the moment kind of in its infancy of PAVE, so a productivity and value-based efficiency approach. I think, again, picking up where Sarah was, that the idea that going forward, there's an element of driving value out of the organisation, and that's the emphasis is an important one.
I think we've suffered as well in certainly the mental health arena in terms of data quality, and we feel, well, certainly in our organisation, that we're just on the start of our patient level costing journey, and I think it's those building blocks of how you can understand how to drive better value. So I think post COVID we need to pick that up and just give it a lot more emphasis in terms of the learning, in terms of how it's impacted on costing at the patient level, and how we can link up across the system. So we're trying to do a piece of work at the minute where we hook up with all of the other, we hook up all the providers in the system around the patient journey, the patient experience and the patient cost. And we are coming up with some barriers, as you might expect, around information governance. I think you've progressed quite well on that, Chris, in Derbyshire, around hooking up the patient pathway. I know that there was a HFMA sort of best practice document around that. I don't know whether you wanted to share anything on that.
Yeah, we've been doing some work locally to try and bring the information together, and to do that we've had to have some quite difficult discussions around information governance, but we've made some progress around that. And it's trying to get the information all in one position, so as a system we can start to make some better decisions around how we provide care over pathways. And I think for me the opportunities going forward around our efficiencies is around pathways and how we provide care across primary, secondary and out of hospital care. And one of the key barriers that we've had in the past is around good information to make good decisions. Now, we're still not there yet. There's a lot of work we need to do around data quality, but we're on a journey. And certainly I would want us to be delivering more of our efficiency programme, both as an organisation, as a system, through that more transformational element, which is more longer term than the more traditional transactional efficiencies we've done in the past.
So can I just take you back a little bit and ask what you were doing during the pandemic in terms of your efficiency programme? Obviously the tariff, the efficiency part of the tariff was temporarily removed. Did that mean the efficiency programme stopped as well? Chris, I think we've spoken about this before. I don't know if you'd like to share about what you've been doing.
Yeah, so from our perspective, we were always very mindful that with a national efficiency of 1.1%, our efficiency programme was always going to be a lot higher than that. And therefore, even though nationally there wasn't a requirement to deliver that level of efficiency due to the cost pressures we had within the organisation and the investments we wanted to make, we felt it was important to continue delivering our efficiency over the COVID period where we could. Now, clearly, because COVID hit around March time, we'd already done a lot of our pre-planning, and therefore there were a number of schemes that just were able to glide into the new financial year without too much input required. We did take a pragmatic approach where management action was required, that some of those didn't progress, and actually some of those schemes were probably not the right thing now in the climate that we're operating in. So we have continued with our efficiency programme this year. I think the danger is more going into 21-22, where we're in the difficult position now where we haven't done the pre-work and we've got extremely busy managers getting ready for a second wave. And building our programme for 21-22 is going to be increasingly difficult because of the alternative pressures that are on with us. So I think we're going to have to take a more pragmatic approach going into 21-22 and probably have a small number of big schemes rather than a large number of smaller schemes that we've done in previous years.
Ian?
Yeah, a fairly similar position, I think, inside the Northern Care Alliance. We certainly required a substantially larger efficiency for the plan than the 1.1%, and So we had a number of schemes in flight. Those that were tactical in nature and were worked up and didn't really make a big pull on the frontline clinical services have been able to continue. Where we have made some further progress, though, is those that are kind of more medium term in the nature and they're going to span multiple years. We've also been able to progress some of those. We've seen slippage in the timescales, obviously, and it's been a heavy kind of concentration on the workup that can be done by those that aren't providing frontline care, but we have been able to make some progress with those, particularly some of the digital pieces.
It was slightly different for Lincolnshire Partnership, whereas a lot of our schemes, as part of the original planning round, were built around efficiencies from new investment, which were just put on hold because of the COVID situation. So we took a stance of just giving a really clear message to all of our budget managers, which is continue to manage within the budget and just ensure that you're delivering value for money in all of your business decisions. And what we saw as a result of that, so we're obviously tracking our costs quite closely, particularly with the COVID related elements, was we had fortuitous gains, for want of a better turn of phrase, around digital transformation in terms of estate costs, travel, printing and stationery, seminars and conferences, etc., etc. So we almost saw our unidentified cost improvement at the beginning of the year being delivered, not through any thought through cost improvement programme, but just as a result of the absolutely astonishing pace of digital transformation that we found ourselves in.
And will you be able to sustain some of that, do you think, going forwards?
Absolutely. So we're in the process now of trying to unpick what's sustainable. So what we leave in place going forward. So my finance team, for example, they never thought they could, but we've managed to produce a real good quality set of financial accounts from home. So it's what does that finance function look like going forward into the future? We're looking at our home working policy to try and work out. What we're trying to do is sort of adopt a digital first, not digital only approach, so that if members of staff feel that they want to come into the office, then they've got that ability to do so in order to feel connected. And that might be something that they're not able to work from home because of their personal circumstances. So being flexible and making sure that there's it's not driven by the finance, it's driven by the workforce productivity, and as a result of that, finance is one of the benefits, as well as reducing our carbon footprint. We're having a conversation at the minute about one of our members of staff, their husband's been redeployed to Scotland, they're in the forces, so they're in the process of handing in their notice, and then it made us think, well, why are you handing in your notice? Because you've done your job perfectly well sitting at home, you can do it perfectly well in Scotland. So it's those kind of sort of nuances that we're trying to embrace now.
We've had a similar situation, Sarah. So we're looking at some of those fortuitous opportunities, but some of them will require being driven as well. So we're doing some specific works around our estate strategy because we recognise that there are increased costs of home working. So actually, to get the real saving out, we've got to start taking some estate out as well. And we're looking to do that both on an organisation but also on a system basis as well, to really try and drive those opportunities.
But should we be talking about system efficiencies now, much more than organisational ones, as we're all trying to work together in a much more system-based approach? There might be costs in one organisation that are generating savings somewhere else, and how would you go about monitoring and reporting that sort of approach to efficiency? I don't know if, Ian, you've got a view on this.
So I think in terms of those efficiencies that sustain themselves through the pandemic, I think the biggest reflection I've got is some of the big signature pieces that we'd planned for they now need reworking because of the change in working practices that we've got. So we had fairly sizable investment with a third-party partner that was looking at digitising the flow of patients through the organisation. And the way it was designed to impact was on length of stay. It would have allowed us to take a sizable kind of part of the bed base out, and release the cost associated with that. Actually, the change in practices that we've got, the need for us to now manage the implications of IPC guidelines mean that however we actually implement that scheme, it's unlikely that we'll be able to reduce the capacity of the organisation. It's going to require us actually to still maintain the same amount of bed base. It's more a question now of can we bring back activity for a lower cost than we were probably going to have to, as opposed to can we reduce the cost of what we were already doing. And it's requiring us to think differently now about what an efficiency scheme is in the future. In part, if you look at efficiency as doing the same for a lower cost, and productivity about doing more at the same cost, actually it's probably an emphasis for a while on productivity as opposed to cost efficiency.
So Sarah, in Derbyshire, we've through our STP we have got a system efficiency plan. Now it was very much in its infancy, and it was about bringing the different organisations' individual plans together all in one place. We could have that transparency. But there's further work going now around how can we move more of that into the transformational space where we've all got a shared ownership of delivery around that, rather than it be the old transactional type. And we did last year put some risk management arrangements around that to start to incentivise it. I think the big opportunities are around pathways. I think provider alliances will be the place where those efficiencies are driven. And I can see examples whereby a pathway may have cost 30 million through benchmarking through things like Right Care. We can see that there are opportunities there, and commissioners may say to us, right, deliver that pathway across your provider alliance for £2 million less, and it will really incentivise providers to look at the whole pathway and how do we reduce waste from that pathway and improve value. And I think from a provider perspective, if we can get into conversations around protecting our fixed costs and our cost base, it then does get us into a much better conversation around how do we best drive the productivity of that fixed cost base rather than taking cash out, which is it's difficult, and it's difficult to engage the staff around that as well.
In terms of how we have to do this differently and thinking about it from a system perspective, it's one of those areas where we'd started our thinking to be different as we were coming into the year. We'd got an historic piece of work that's been 18 months old around outpatient productivity that was primarily focused on how we improved utilisation of outpatient slots, how we reduced DNAs, how we got standard clinic templates, the consequence of which would have been that we got much greater volume through and were able to make a greater return from each clinic. The consequence of that, though, at a system levels, felt as a cost in the commissioner side of it, facing fairly sizable challenges across some parts of our economies. We were looking at how we might take and think about a system control total before they were kind of being talked about, and we were looking at whether it was possible for us to try and set the combined deficit in a single place and work on programmes of work that would have allowed us to draw that or to reduce that deficit down. And one of those areas was refocusing the energy of the outpatient work, so rebranding it SWAP, so a system-wide outpatient programme designed not to just increase utilisation, but how we might reduce the demand for outpatients overall, how we might see advice and guidance becoming a key part of it. How it may be that we use different levels of monitoring and how we are able to take greater level of risk as a consequence of that monitoring on the callback of patients, all of which reduce the overall demand for outpatients. So you do see that some of the thinking was already there, but certainly the challenges of the pandemic have forced us as a system to think about that as well.
Yeah, I think we're just sort of touching on it there. I think one of the challenges is around, we've worked really hard sort of as a group of providers and secondary providers and commissioners to come together on system issues. It's getting primary care networks to the table, where a lot of the cost in the system is driven by clinical decisions and referral behaviours in primary care, and how do you bring a very disparate, we've got 13 networks. How do we hear their voices? How do we bring them to the table? And I think we're at the start of that. As Chris says, it's a journey, but there's so much opportunity there to really unpick what's driving the costs in the system. If we can just build those relationships, share the information, get the clinicians together to talk that through. And I think the whole temporary financial regime has been really interesting in terms of, we haven't got into that, well, who's going to pick up the cost conversation, which usually takes, from my experience anyway, takes up everybody's energy and delays anything from changing. So, just as an example, the cost was sitting with our trust in terms of providing staff wellbeing services to the rest of the system to help reduce stress, sickness, agency costs, so the savings elsewhere. But we didn't have to get involved in that conversation during, the financial regime. We just got on with it. So it's how we really need to make sure that we were able to pick up on that and keep it going forward into the future.
So can we talk about efficiencies now? Is it the right time? Obviously, COVID's ramping up again. Are people receptive to having these discussions, or do we need to back off a bit for a while longer yet?
Well, as part of our month 7 to 12 planning, we have been requested to include efficiencies and clearly identify them in the plan, which we have done. But it isn't about taking up all of the capacity, very precious capacity of clinicians and service managers filling in quality impact assessment forms and all the bureaucracy that goes with it. It's about really focusing on the learning from months 1 to 6 as a result of the pandemic, and readjusting our approach to that financial planning, because this is how it's going to be going forward. So really maximising those benefits. So we are having to have the efficiency discussion, but it's taken on a different flavour, and it feels a lot more positive, I think, as opposed to what we talked about throughout this session around not just talking about cost improvement.
So, Chris, you mentioned earlier on in the discussion that you're worried about next year and not having made the preparations necessarily this year. So what are you thinking about? What are your plans for going into next year? How are you going to approach that problem?
I think it's about taking a very pragmatic approach. I think as colleagues have said, that there have been some opportunities that have come up through COVID, particularly around the digital, but also about how we work differently. So I can see next year that being a key part of our plans going forward. One of the sort of the unintended benefits also for us from COVID is that we've had to do quite a lot of work with our acute colleagues around better understanding our capacity. And I think our acute colleagues have much better models around demand and capacity than we've had in the community. So we've took quite a lot of learning over the last 6 months, starting with bedded care, but then we've expanded that out into some of our other service lines, our key service lines. And by the end of December, we'll have a good proportion of our services covered by much more robust demand and capacity modelling, which enable us to manage some of the variation that we're seeing across our services. So I can see that that's going to be a big area of our focus around looking at that unwarranted variation within our organisation. And then the third element will be around working with the system around what can we do differently as a system to drive value better. So I think there's probably the three elements: the learning from COVID, particularly around digital, the unwarranted variation within our organisation, and then thirdly around the system and what the opportunities are to do things differently.
And Sarah, you were nodding through that discussion.
Absolutely, yeah. So it's that demand and capacity piece. So we're working with other mental health providers across the East Midlands on a demand and capacity model in terms of trying to forecast in the short, medium and long term how the pandemic and potential economic impacts will have an impact on the population's mental health, and what that looks like in terms of what capacity is required to be able to deliver that. And as Chris says, I think, acute, because of payment by results, they've had to be absolutely on that in terms of their data quality and their modelling. But I think we've kind of been forced into it in other service lines because of the nature of the pandemic. And I think in terms of the response to it, I think we need to keep hold of some of the great system working that we've had through the response phase, such as working with the police and public health colleagues as well around population health management. So I think there's a lot of good opportunity there.
How are you thinking about it, Ian? Because obviously you've already got some of the demand and capacity models in place that Chris and Sarah have mentioned.
So I think the first thing that the challenge that we're facing is we've got historic information on our cost base. We've got service line reporting in and patient level costing, but actually the cost base has changed. There are the windfall opportunities that come from reduced travel, reduced expenses that are in part small in nature, but there are windfall opportunities across the piece, but there are significant additional costs from zoning, from the way in which patients flow through the organisation. And the key piece for me, I think, is to understand in the first instance what the emerging new underlying cost base is. We're seriously looking at whether we've got the capacity in this next quarter or so to think about undertaking some sort of zero-based budgeting or zero-based budgeting light process to allow us to understand a new cost base. So that's certainly one of the things that we're looking at. The other thing that we're looking at probably builds on the discussions we were having but never concluded as we came into COVID, which was around a system kind of level target. I think we need to, PBR isn't going to work into the future, particularly for some bits of the system. And it's whether we can devise a way to allow contracts to cover certain fixed costs and step costs and think about what the real marginal costs of activity are and how we can impact on those at a system. And so it's probably shifting away from the traditional means of contracting and starting to use other mechanisms. They're the two things that I think strategically we're starting to look at that may change the way we think about the efficiency productivity piece in the future. So though some things are changing and we have to think about it, differently, the one thing that's common and is the constant, I think, is where we've been successful in the past in driving improvement is where we've taken clinical colleagues with us and where we've aligned it to the quality issue and the value issue. And however we emerge on the other side of this and however we establish it going forward, if we haven't found a way of maintaining that link back to the quality, to the patient experience and into the value equation, then we're not going to be successful. So the lens may change, but actually some of the key ways in which you drive it are going to have to be common. Otherwise we know we're not going to be successful.
Well, thank you very much for your time, all three of you. It's been really helpful, and it's really reassuring to hear actually that even though you're across three different sectors, the challenges and the issues that you're facing are all much the same, and you're all approaching things in much the same way. So hopefully that's been a really helpful session for the people who are listening. So thank you for that. If you would like to find out more about efficiency programmes or any other topical issue, then don't forget to join us for our virtual annual conference. The 12 days of conference will run from 30th of November to 11th December. There is something for everybody in your organisation with a student conference, learning labs and national NHS speakers across the 12 days, and you can discuss questions with colleagues from across the country. You can find out more on our website, hfma.org.uk. You can also find information here about the HFMA and how to become a member. Thank you for listening to HFMA Talk, and don't forget to subscribe to this podcast to keep up to date with future episodes.